Okay, so evening, everybody. Just as a reminder, the content of this presentation is proprietary and confidential information of the Florida Firefighter Safety and Health Collaborative. It is not intended to be distributed by any party without the written consent of the collaborative. Attendees should note that the educational component of this session is being recorded and will be published on the Florida Firefighter Safety and Health Collaborative's YouTube page. To maintain complete confidentiality, an announcement will be made before the recording begins, and only the presenter will be identified during the recording. Therefore, to ensure complete anonymity, all attendees are asked to mute their microphones until announcement is made that the recording is complete. Presentations are intended for educational purposes only and do not replace the independent professional judgment. The ideas expressed in this presentation are the professional opinion of the presenter and do not necessarily represent those of the collaborative or its constituents. Before acting on any of the information presented, attendees should consider the appropriateness of the information as it pertains to their individual situation and seek independent professional advice should any concerns arise. If you or anyone you know or what are in or believed or perceived to be a situation that is or may become harmful, please reach out to the National Domestic Violence Hotline via phone at 1-800-799-SAFE, 1-800-799-7233, or through their website, thehotline.org, or as always, dial 911 in the event of emergency. With that, I really want to welcome you all here this evening, first responders, families, friends, the community, and really the state of a whole, I mean, the country as a whole, who really didn't choose to be a part of this Surfside tragedy. Trauma, though, is a fact of life. However, it doesn't need to be a life sentence. I applaud you all for being here and for taking the brave first step to heal yourself, to heal your families, even though it still may hurt very deeply. Tonight, we welcome Dr. Beidel, Executive Director of the UCF Restores program. When tragedy and trauma affects a first responder, she and her team are leaders in the treatment of lasting effects of trauma on first responders. But when buildings collapse, just like they did over a month ago, she and her team did more than just say we're there. They were here. They were in Miami. They were on site. They were supporting first responders firsthand. We are so grateful that Dr. Beidel is here to speak to us tonight about some of the first steps and supporting the families, the friends, the co-workers, and even the departments can begin supporting and promoting healthier outcomes after traumas like we just experienced. Recovery is a process. It takes time. It takes patience. It takes work. It does not happen overnight. And some days it takes every damn thing you have to get through it. Trauma creates change that you don't choose. Healing, though, is about creating change that you do choose. So please join me as we welcome Dr. Beidel to start this very important conversation and to start the process of healing. Thank you again, Dr. Beidel, for being here. The floor is all yours.
Oh, thank you very much. And thank you for what I really consider to be a privilege, not just to be here tonight, but to have this association with the Florida Firefighters Safety and Health Collaborative. For me, this is one of the things that's been the highlight of my career and one of the things that I'm very proud that we're a part of. Let me see if I can share my screen here. Okay, so I want to talk about trauma, what trauma is about, how we expect some recovery, and we'll talk specifically about some of the events that went on down at Surfside and some of the things we might expect in the aftermath of that. But I want to start just for a moment because I'm not sure that everyone knows about UCF Restores and all the things that we do there. So just for a minute, let me give you an idea. We are a resource, and we are proud to be a resource for all of you throughout Florida. We started in Central Florida, but thankfully we are increasing our reach, and many of our services are available at no cost for residents of Florida who are experiencing traumatic events and the aftermath of those events. And really what we are is what I think of as a clinical research center. And I am really dedicated as a clinical psychologist to understanding what conditions are like, developing treatments that then may be helpful for them, and then changing the treatments if I find out they're not working. So I'm someone who will always try and make treatments better. And I often encourage people who come for our services to tell me what's not right, tell me what's not working, because I want to make it better. In addition to those clinical services that we provide, as I said, we do research. We do research not only on treatment, but also on resilience and prevention. And then, as many of you know, we have an educational program because we're part of the University of Central Florida, and we train undergraduates, graduates, and postgraduates. And I'm very happy to say that the people that we select to come to our program either have prior careers in the military or as first responders, or find after working with us that that's where they're going to make the rest of their career. So we put some kind of bug in them that allows them then to want to do this. So I don't know that I have to tell all of you what trauma is, because you do experience it a lot. But, I want to say that that word is sort of thrown around a lot these days, and that we don't always have the same understanding about it. But it really is an event that really involves actual or threatened death or serious injury or threat to physical integrity. And we saw all of that when we're talking about what happened down at Surfside, because certainly there are a number of people who were tragically killed when that building came down. And for all of you who were down there and who were working down there, even during that time, not only the things that you saw, but the fact that you were working in very dangerous and conditions. So, working underneath parts of the building, going around on the pile. So I think of that whole event that was going on as a sort of traumatic event that went on for almost a month. That's really unheard of. I mean, even if you think about most traumatic events, perhaps with the exception of 9/11, to have a continuing event going on where people were being continuously exposed to death, to danger, to the possibility of physically being injured if the rest of that building had come down, that's really, really unusual. And the aftermath of that is going to be something that we're going to watch very carefully, because we don't quite know what the long-term effects of that are going to be, either for the survivors of those events or for the first responders who were down there that day and that week and that month. Up to 90% of Americans are going to experience some type of traumatic event in their lifetime. What distinguishes first responders, of course, are the fact that really your jobs are about trauma and about experiencing traumatic events. Now, not all of them may affect you in the same way, but when we look at the types of traumatic events that could precipitate post-traumatic stress disorder, there's a lot of them there to which you respond and to which you are then exposed. So you're in a unique position where a lot of what you do is going to put you at higher risk for developing some type of traumatic response to these different events. And if we look at who's most likely to experience it, as I said, it's people who have the direct exposure to the sights and the sounds. So I know, having been down there and having seen the destruction from that building, that changed me in a way, because the sight of that pile, how big it actually was, I told people, was not the same as just looking at it on television or in a photograph. Actually seeing it there, actually hearing everything that was going on, the smells that were associated with it, really affects you differently than if you're just watching it secondhand on television. And having that direct exposure, again, can create higher risk. Now, it's not going to be the same for everyone. And that's one thing that I would like everyone to take away from this presentation, is that there is no singular response to a traumatic event, even as one as extensive as the Surfside building collapse. Everyone's going to be responding differently, and everyone's response is appropriate, both in terms of what they feel, how deeply they feel it, and how long it might take them to recover. So we should never ever try to compare ourselves to the person next to us. We don't have the same background, we don't have the same experiences, and so it's always going to be a different type of response. So please keep that in mind and understand that as individuals, we're all going to respond in a different fashion. But if we look at the statistics, we can see that there's about 400,000 first responders who have some symptoms of post-traumatic stress disorder. So this is something that is common, and about 33% will develop PTSD. That's much higher than in the general population, and it's also about as high as what we see in military combat. So again, being at high risk for this is something we want to think about and something we want to be proactive about. So how we can move forward from experiencing these types of events. So what's the typical reaction to a traumatic event? Well, the typical reaction is really the same symptoms that we have of post-traumatic stress disorder. But in the early stages of a traumatic event like this, like Surfside, we expect people to have these type of reactions. So we expect people to have some fear or some anxiety. I remember saying to some people that, my hotel room was on the 8th floor of a hotel, and I remember thinking, I'm up pretty high. Might the same thing happen here? So you have those kind of worries. That's common after these types of events. To have difficulty sleeping, possibly because of nightmares, possibly of being very stressed. To have difficulty eating, or have trouble re-experiencing the event. So thinking about certain parts of the event over and over and over again. So maybe the discovery of some human remains might be sticking with some people, and it keeps coming back into their mind. They can't sort of put it away. We might find that in this short term that people might have urges to avoid the situations that are really associated with the events. So after the Pulse nightclub shooting, for example, we found that there were police officers who couldn't put on their uniforms because it reminded them of what happened that night. We saw people who couldn't drive down Orange Avenue because it would automatically trigger a reminder of that event. Some of the things after Surfside we don't quite know, but I have a feeling that for some people, the sights of those cranes, the sounds of the jackhammers, those kind of construction noises that were moving around to remove the debris could I said, become a trigger for some people, and they may find that they want to avoid those types of places because it then reminds them and has them flash back to what was happening down at Surfside at that event. And then also just feeling very keyed up on edge. That's really common in the immediate aftermath of these types of traumatic events. So people are going to vary in these symptoms in the early days. And for right now, if people are telling me that they're having some of these symptoms, my response is, I'm not surprised. This was a really traumatic event. This was an extensive event. So I wouldn't be surprised that these are some of the things that are happening. As I said, there's no single timeline for recovery. But what we do know is there are these different responses, and this is an important slide to look at. And that is really that for the most part, let me see if I can use my little flashy laser pointer here. Most people, if you can see this line down here, this dotted line, are going to have the type of response where they're going to have some symptoms at the time of the event, and those symptoms are going to gradually decrease until they come back to really what is we might think of as their baseline level, the way they usually are. And so what we see in this group that we call resilience, which is really the largest group, is people who have symptoms in the short term, but then quickly go back to their baseline level of functioning. As clinical psychologists, we don't worry about this group, and we don't want to interfere, because what happens is sometimes if you interfere too quickly with people and provide treatment too quickly, you interrupt that normal recovery process, and then you can make people worse. So we want to monitor that and make sure that people are starting to feel recovery. The same thing with this group here that is actually called the recovery group. Those are people who are going to have moderate distress for a period of time. They're going to report a lot of those symptoms, and then those symptoms are going to decrease on their own without treatment. Again, we try not to interfere with people who have a natural recovery process. We want to monitor them, and we would suggest treatment if we saw things like alcohol abuse, suicidal ideation. Those are things that would make us change our mind. But what you can see from these percentages is that for the most part, most people are going to be resilient or recover from these types of events without any real need for treatment. So that's the good news. The other two groups, the chronic group and the group that has delayed responses, are the ones that most likely are going to come to our clinic or seek out help from someone, because even after a year or 2 years, they're continuing to suffer as a result of these events. And there's no reason that they have to, because there are good treatments that are available. So we look for recovery and resilience. We intervene when we see chronic and delayed responses. This is a slide that, again, just looks at the different kinds of traumas and the length of time that it takes for people to recover. Now, unfortunately, a building collapse is not one of the different types of traumas that is included in this group because of the highly unusual nature. But again, what we see, and this is over 20 years, that for the most part, a lot of people will recover, although there's still always a percentage that are going to continue to have an episode of PTSD, perhaps even as much as 20 years later. So we want to be able to identify those people and help them and help their families cope. So again, the symptoms that we talked about, the fear, the anxiety, the nightmares, the flashbacks. Don't know if you're familiar with the term flashbacks, but it's something where a person will suddenly feel as if they're re-experiencing the particular event. So the best example that I can give is one that a Vietnam veteran that I was treating shared with me a number of years ago. He loved to work in his garden, and he came in one day for his session, and he said to me, "Dr. B, I got to tell you," he said, "yesterday I was out in my garden." He said, "I was working. I looked up, and at the other end of my garden, there's a Vietnamese guy working in the rice paddy." He said, "Now I know that that guy was not really there. But I'm telling you, Dr. B, I saw him as much as I'm seeing you sitting here right now. So this idea of re-experiencing the event of a flashback, it does not mean you're crazy. Okay, it's not psychotic, doesn't mean you have schizophrenia. It means you're having a flashback from a horrific traumatic event. It's common. It can be quite unsettling when it happens. And it's a result of the high level of arousal that people with post-traumatic stress disorder have. So it is something that can be treated, that people can overcome, but it can be quite frightening when it occurs. And again, I think for people down at Surfside who may have seen some of the more horrific parts of that recovery effort, or who may have been involved, for example, when certain remains were discovered, that they may have some flashbacks later on about those particular events, particularly if they're triggered by something like a sound, a sight, or a smell. In addition to the cranes, another site that I'm wondering if might become a trigger for some people, because we all talked about it when we were down there, was those bunk beds that were at the top of that tower. You know, just thinking that there may have been children who might have been there, or the hardwood floors that were sort of hanging vertically. All of those could become triggers for people re-experiencing the symptoms, having difficulty sleeping for maybe a few nights, having nightmares. You know, with PTSD, when it gets quite severe, people may be sleeping perhaps 3 hours a night, and they're afraid to go to sleep because they don't want to have the nightmares. So we want to try and identify people having those and intervene, because if you can't sleep, you're not going to be able to overcome the symptoms. We talk about people having post-traumatic stress disorder when their symptoms are present for at least a month and they're not getting better. So after a month, maybe two, of people continuing to have high levels of symptoms, difficulty sleeping, a lot of fear and anxiety, perhaps a lot of anger, nightmares, re-experiencing the events, those are the times when we decide that perhaps treatment might be most appropriate. The other time, of course, and I know that my colleague Dr. Rosick is going to be coming to speak to you, is when there are thoughts or plans for suicide. We don't wait if we know that people are having thoughts about suicide or actually have a plan to complete suicide. And of course, what happens? You know, we keep stuffing these things. We keep trying to get it all together. We keep trying to push it down, Don't talk to anybody. Just keep it quiet, push it down until that trash can overflows and there's no place else for it to go. And then people either start to behave in ways that's going to get them into trouble, into difficulty with their families, difficulty at work. But the trash can is overflowing. There's no place else to put all those negative feelings. And then it's time for people to begin to seek some kind of treatment, whether it's peer support, whether it's formal treatment, but something at that point really has to change. So because not all of you, luckily, have a DSM-5 and know all the symptoms of post-traumatic stress disorder, these are some other changes in behavior that could indicate that something is happening, that something is going on. And that could include things like increased sick days. Okay, so someone who was going to work all the time, now they're not going to work anymore. They're calling off a lot more because they don't want to be in there. They don't want to face whatever it is, or they haven't been able to sleep. Poor work performance is another one. So the guys who were always really good, the women who were always really good at X, Y, or Z, suddenly they're not doing the job anymore. They're really goofing up. You might see people avoiding certain types of job requirements or types of calls. So we have people who come to us and say, if it's a pediatric call, I find somebody else to go on it. I can't do it. I can't take it anymore. Or not wanting to do certain things that were part of their job before. And decreased social interactions is another one that people start to isolate, right? So they're not coming and having meals with everyone. They're not working out with other people. They're not goofing around. They're really kind of isolating and maybe just playing on their phone all the time. And that you notice that there's a definite change in their level of social interaction. Another one is increased anger, increased irritability, really flying off the handle more so than usual. This is not someone who's always been an angry person. This is someone who wasn't an angry person in the past, and now everything causes them to snap. And also increased alcohol use, particularly among men. We've known for a long time that men try to deal with anxiety with alcohol. And it happens in certain ways. We found it a long time ago when people with panic disorder and agoraphobia, men would, rather than staying home like the women did, men would use a lot of alcohol in order to get through the day and try to manage the panic attacks. Alcohol use is a problem for many, many reasons, but if I forget to say it later, one of the problems with alcohol use is that people use it to try to sleep. Okay, I've done this myself on a red-eye flight. Oh, I'll have a couple glasses of wine and I'll fall asleep on the plane. It never works because passing out is not sleeping. And this is critical because sleep is necessary for us to put our memories, including our traumatic memories, into our long-term filing cabinet, which is the hippocampus of our brain. And those memories get filed and get taken out of the front of our brain and put into the middle part of our brain and into our hippocampus and our memory storage area when we dream. When you pass out, you don't dream. So if you're not dreaming, you're not taking those things that happen to you in the day and making them memories. What's happening is they're staying in the front of your brain and you're reacting to them as if they are going on in real time, rather than as if it was a memory, something that happened weeks ago, and now you can put it in its place. So sleep, we understand now, is critically important to helping people process memories and put them in a safe place. And when you're not sleeping, when you're using alcohol to help you sleep, you're just making the situation worse because it's not helping you sleep. We also see the other changes in behavior might really be something like DUIs or other kinds of offenses. These don't automatically mean PTSD is there, but it certainly means that something is going wrong, something has happened, people are having a response to a traumatic event, and it's the time for all of us, those of us who know that person, to try and intervene. UCF Restores started with working with military personnel. And at the same time, back in 2015, one of our graduate students, Madeline Marks, along with my colleague Clint Bowers, started to look at peer support training for first responders. And they were going along doing peer support training, and then the Pulse nightclub shooting happened. And that morning, Madeline got a call from Jeff Orange asking if we could come down right away. And Maddie called me and said, they need us. And I said, well, we're going. So, which is what we did. People were like, how are you going to pay for it? I'm like, I don't care. I'll figure it out. I'll figure that part out later. I work for the university. I'll figure it out. So we went down, and although that day, nobody really wanted to talk to us because they'd been up all night working this scene. A couple days later, we started to do some debriefings and started to talk to people and started psychological first aid. And that, in some ways, really opened my eyes to the severity, frequency of trauma that first responders and all of you experience. It's not that I didn't know it, it's that I didn't think about it, and I didn't think about how frequently it happened. And so since that time, we looked at each other and we said, what do we do? And we're like, well, we're going to try our program. So since that time, these are the number of people that we have seen. We're actually up to 499. These slides are, we're still collecting all of the data, but we've seen at this point 499 first responders since the day of the Pulse nightclub shooting. Not all of them, as you can see, were because of the Pulse nightclub traumatic event, but certainly in the beginning, that's what we started, and that's what started what I now think of as this wonderful journey with so many new colleagues. But I want to show you, these are the problems, okay? And again, it goes back to my point that everybody came in because of a traumatic event, but not everybody got a diagnosis of post-traumatic stress disorder. So we saw 45% certainly did get a diagnosis of post-traumatic stress disorder, but people also had what we called other types of trauma disorders. Some people had alcohol use disorder. Some people had pervasive depression or major depression or generalized anxiety, adjustment disorders. And some people came in and they didn't have a diagnosis. They either came in because they were worried about something, or they just wanted to have an evaluation, or a spouse said, go get checked out because something seems to be wrong. So a variety of responses to traumatic events, because we're all individuals and we all have different ways that we process this and different experiences. So again, sometimes people who have had prior events have a more difficult time when another traumatic event occurs. And these are the types of calls, and you all know this better than I do, but by far the biggest are the pediatric calls. And for those of you who may be down in the Osceola area, there have been a high number of pediatric drownings this year down in that county. A very tough situation to deal with. I understand that most of them have been either at the parks or also at B&Bs with people who, have rented someone's house and don't have a pool in their own backyard and don't know how careful you have to be with children in swimming pools. But this gives you an idea of the types of events that are most likely to precipitate calls for treatment. And you can see, again, they vary. All of these are in first responders, even when the trauma might have been related to military service. And when we were starting to get money from the state of Florida, I had someone from the Panhandle call me, first responder, and he said, I want you to tell them one thing. I'm retired. I've seen one too many suicides, one too many homicides, one too many car accidents. I can't do it anymore. So again, it's not always the one big event like Surfside, okay? It can be a number of small events that then lead someone to a tipping point. So although we certainly worry about big events, we also worry about this cumulative number of small events, almost like that old straw that broke the camel's back. That's what we have to think about when we do this. And we've broken them out. Firefighters and paramedics are the blue lines, so you can see the difference based on the different types of calls. So what can we do? Can we prevent PTSD? I'm not sure we can always prevent it, but there may be some things that we can help do. And one of the things that we know is a good protective factor is ongoing peer support. Okay? That's something that you have in your culture. You're way, way ahead of everybody else. And everybody else now is starting to copy the firefighter peer support foundation that you all have built. Okay, so thank you for doing that. It's critical. It's keeping people alive, and it's spreading. The medical examiner this morning from Orange County was talking about the fact how we had done a similar presentation to them a couple years ago, and they've developed their own peer support network now for people who work in medical examiner's office and have found it to be effective and helpful for people. It's useful because, again, you want to talk to people who understand your culture. And I know that so many therapists don't understand firefighter culture. Thankfully, with the help of the collaborative, we're starting to change that. But I understand that. What breaks my heart is when we get a call from a firefighter who says, my therapist just fired me, right? My therapist says I'm traumatizing her more than she's able to help me. And then the conclusion is, I must be really messed up, I must be really broken, and there's no hope for me, and therapy can't help. Not true, but that's what people think, because there are so many people who think they can take care of people with trauma. We heard the stories down at Parkland. The stories that we heard from Parkland were psychiatrists running around outside the perimeter with their prescription pads asking who needed Prozac, right? Acupuncturists who were setting up tables there to try and give people treatment. People who don't understand the culture are not going to be very effective. And peer support is, of course, the first level, talking to people who have been through it with you, who know it and who understand. And in case I forget, when we were doing the debriefings down at Surfside, someone came up to me and said, could you have a 3-week intensive outpatient program just for us? Just for the people who were down at Surfside. So rather than mixing in with other people, having special groups just for people who were at Surfside and who felt the need for some treatment. And of course, my answer was, sure. So we'll do that. We'll do that. And so that people will be able to, again, be in a group, get some professional help, but also be with peers who went through the same thing and who understand what that was like, because that was a unique experience. Right? Again, it's easier to talk to your peers than it is to talk to someone in the mental health field. So again, I told you might recognize some of the people that are in that picture. That's me with my pre-pandemic hair. This is what pandemics can do to the color of your hair. But we've been working on this peer support program for a period of time now. And guess what? Peer support has lots of positive features. It actually can provide significant gains in cognitive functioning. What do I mean by that? Well, if you're less stressed, you can pay attention better. You can concentrate more on your job. So having a network of trained peer support people that you can talk to is going to help you be able to think better, to do your job better, will improve your social functioning and your overall functioning and decrease your psychiatric symptoms. So we're very proud of our REACT peer support training program. We have, this past year alone, even doing it over telehealth, trained over 400 new peer support personnel. We have trained people in a number of different counties, and we're now reaching out to places. Ohio is interested, Indiana, a number of different places. So peer support is crucial. And as I said, you all are leading the way. Something else we have now that we've thought about that might be great for all you resilient people is something we call a single session consultation. And this is a service that we're offering. It's not therapy, but it's consultation for people who have a lot of resilience, but who at the moment are feeling very overwhelmed or stressed. It's a 60-minute appointment with one of our therapists. They help you develop a plan to manage the stress that you're going over and feeling right now. This could be related to Surfside. It could be related to COVID-19. It doesn't matter. We have same day appointments. There are people who are answering the phone. If they don't answer the phone, it's because they're talking to somebody else about it. And all of our services are at no cost. So it's for essential workers in Florida. Of course, first responders are part of that. So I just want to bring that up if you're interested in something like that, or you think you may just need to talk to somebody once. We know that about 80% of the people who have called this line, when we call them back at follow-up and say, how are you doing? They go, I'm doing really well. You know, the plan worked, I'm keeping it in place, and I'm feeling pretty good. 20% are like, I think I need to come see you. But anyway, it's a resource that we offer, and it's good for people who may not have the time to come to treatment. I want to talk quickly about our treatment. Some of you may know that we use imaginal or virtual reality exposure therapy. Exposure therapy is the most scientifically validated treatment for post-traumatic stress disorder. Thanks to all of you, we are about to roll out a new VR system that has scenarios for first responders, first of its kind in the country and probably the world. So thank you for all the help that so many of you gave us in developing virtual reality scenes. What's exposure therapy? If I asked you, how do you get over your fear of a dog? You would probably tell me you have to be around a dog, but it's got to be the kind of dog that actually created your fear. So if you were bitten by a German Shepherd and I bring in my 17-pound little yappy terrier, you're not going to get over your fear of German Shepherds. It's the wrong dog. So in the virtual reality, we can tailor that exposure therapy to what your traumatic event was. This does not mean that we want you to become comfortable with processing people who have died and taking them out of the concrete. When that event occurred, when you were down there, all of the things that were in your environment can become triggers, like I said. So you may not be able to hear the sound of jackhammers or see the sights of cranes or smell the smells that were down there without having a flashback. What we need to do is break that association between something that used to be innocuous, a crane or a jackhammer, and the event at Surfside. We need to put that in the long-term part of your brain so that once something awful was happening when you heard the sounds of jackhammers, but not every time you hear the sound of a jackhammer are you going to flash back to that kind of horrific event. So that's the idea of exposure therapy. Another example, we're not trying to make people be comfortable with being sexually assaulted. What we're trying to do is get them back into their bedroom without them having a panic attack if that's where the assault occurred. We wrap that with group treatment because what we know is that exposure therapy alone is not going to take care of all of the parts of PTSD. So we spend a lot of time on sleep hygiene, as I said, not only talking about not using alcohol, but not using the devices that we're all using right now, right? We all try to go to sleep by playing on our phones and watching TV. It's the wrong thing to do. Those devices emit blue light. Blue light tells your eyes and your brain to wake up. So when you are trying to sleep by playing on your phone, you are doing the exact opposite of what you need to do to go to sleep. So there are some good sleep hygiene tips that we talk about and help people get back to going to sleep. We do some sessions on anger management, right? Things are going to make us angry. We don't try and eliminate anger. We try and eliminate inappropriate responses to anger. We try to talk about social reintegration, getting back out and doing things, and behavioral activation for depression. And this is something that we might see again in some people after the Surfside event. This idea that some people survived and some people didn't, and feeling some kind of moral injury or guilt about not being able to save some of these people, particularly in the very early time. after the event happened. So all of these things are necessary for us to work on. Everyone has an individual treatment plan, but our program is 5 days a week for 3 weeks. Housing is covered as part of the treatment program for people who live outside of the Orlando area. The legislature has funded us generally to run this program, so it's all available at no cost. It's 3 weeks, and at the end of 3 weeks, 76% of first responders no longer meet the criteria for post-traumatic stress disorder. So as I said, we're preparing if we're going to need to do this. The program is available for anyone in the state of Florida. And I've sort of gone over that. This was an example from the Pulse nightclub shooting of what we did and how we were able to work with the people who were there. So what about families? You know, how can you help? How can you help someone who may be suffering with this after this traumatic event or any traumatic event? Well, the first thing is, of course, to learn as much as you can about post-traumatic stress disorder. Understand the kind of things we've talked to tonight. One of the issues that comes up a lot between spouses is this issue of communication, or maybe lack of communication. So asking someone, well, what was it like? And people not wanting to talk about it, okay? One of the things that we hear is how this is really misinterpreted. So we hear from a lot of people, I don't want what's in my head in my spouse's head. I've seen horrific things. I don't want to talk about those and have those images. You know, now my spouse is carrying them around. The spouse, on the other hand, thinks he or she doesn't love me anymore because they're not talking to me. They're not telling me what's going on. So understanding that in many cases, not talking specifically about these traumatic events is a way of protecting the ones that you love, and that's critically important. But what you can do to help support someone is let them know that you want to listen. You want to listen, but you don't want to ask a lot of questions. You want to let them tell you what it is that they want to talk to you about. And also understand that it might not be the right time to talk. But letting people know that you're there and that you want to listen is really important. When the whole COVID-19 first started, I have a very dear friend who's a psychiatrist in Milan, and she was in that worst part of the city where the whole city was locked down. She was a psychiatrist, so she's an MD. She had to stay in the hospital. And I said, what can I do for you? And she said, every day, send me a little note on Facebook. I just want to know that someone is out there and someone is thinking about me. And that's the best thing we can do when people are suffering from these types of traumatic events, is to just keep reminding them that we're there, that we want to help them, that we want to listen to them, and that we're going to support them even when it's not the right time for them to talk. Another thing is to plan some family activities. So plan some things that might be a distraction. So rather than sitting around, do something that you can do as a family, even if it's just taking a walk together, playing outside with the kids, something that in some way will help someone get those thoughts out of their mind, at least temporarily, and get them doing something that they used to enjoy and they used to have a good time doing. Physical activities are really very good if you can do those. Our bodies are set up so that physical activities, not like, you know, jogging 26 miles, but even just walking a little bit briskly, releases something in our brain. They're called endorphins. Endorphins are natural mood elevators, and they work the same as an antidepressant. So, because it's the same drug. So, it's something that you can do. It can elevate your mood. It's a good way of dealing with mild levels of depression, not severe levels of depression, but mild levels of depression. So doing some physical activities can help you feel better, at least for a short period of time. And stringing those together can help people start to deal with the long-term effects of some of these traumatic events. And then, as I said, again, encourage contact with family and members and close friends. As Dustin was saying earlier, reach out to the people that you love, stay in contact with them, make sure that they know that you care, that you're thinking about them. Can be very important in helping people. As Dr. Rosick will tell you next month, one of the things that's most likely to prevent someone from completing suicide is reaching out to that person. If you can reach out, you may not think you're doing much, but you may be the person who pulled them back, who interfered because you cared enough to do something, you cared enough to reach out. And you don't have to say, hey, I'm really worried about you. You could if you want to, but you just have to say, hey, I've been thinking about you. You crossed my mind today and I wanted to reach out and say hello. I saw on Dr. O'Dare's Second Alarm Project, she had a list today of 10 different things that you could use to reach out to someone. So it was a terrific list, but it's the act of reaching out. Don't think you have to say something specific. You just have to say something can be very helpful. You have to take care of yourself as well. Okay. So the best way to help someone is to also make sure that you are in good shape. And I talk about this with our therapists all the time as well. They need to take care of themselves. People say to us, well, how do you all keep hearing all those things all the time? Well, we do some self-care. We step back when we need to. We say we need to take a break. We take our vacations. So we take care of ourselves so we're better able to help other people. And first of all, reminding yourself that you don't have all the answers. None of us do. Okay. We do the best we can, and that's all we can be expected to do. But if you're doing what's right in your heart, then you're going to be doing the right thing. You can't make a mistake as long as you're reaching out with love and with care to other people. Things may change slowly. People don't, as I showed you before, people don't always recover in a couple of weeks, and no one should be expected to recover from this type of event quickly. Okay? Some people are going to recover more quickly than others. Some people may think they're doing fine and then may have something come up later that's going to be problematic. So again, recovery is going to be different for everyone and things may change. Take care of your own physical and mental health. That's critically important because you've got to do that to take care of your family and take time for yourself. Make sure you do that. And it's normal to feel helpless at times. I'm just say one more thing because I know I've been talking a lot, but for all of you out there who are first responders, you do a job that most people can't do. And thank you for doing that for the rest of us. And you can tolerate what's intolerable to other people. So, and you are more resilient and you can bounce back, but you do, as we saw in Surfside, you have a front row seat to some of life's ugliest moments. You know that going in, but it doesn't mean that you're not affected by it. Okay? You often forget to take care of yourself along the way. And there may be a time when you may need to talk to someone. It may be in your best interest. Think of it as an opportunity to learn skills so that you can go back to your job and finish your career, because we want you out there. We need you out there. We always count on you to be there for whenever we need you. When the bad things happen. So thank you for doing that, and thank you for giving me the opportunity to speak to you this evening. I really appreciate it.
Dr. Beidel, thank you for taking the time to do that. So just a couple of reminders here that you can reach out to UCF Restores for that single session consultation program, 407-823-1657. You can visit ucfrestores.com. And I'm just going to quickly share my screen to show two things. Don't forget, through UCF Restores and the hard work of our own collaborative members and Dustin Hawkins and UCF and all sorts of people, you can go to Redline Rescue. You can find a culturally competent clinician in your area, or find a peer supporter in your area, someone that you can talk to if a clinician is just not where you're at right now. So you can visit the redlinerescue.org website that is also being built out to include Blue Line Rescue and our families as well. Our families will have their own peer support network, and we are working on creating peer support for our families as well. So we're so grateful to be in the presence of UCF and under the guidance of Dr. Beidel. The last thing that I'll share, and then I'm going to open the floor for questions. As Dr. Beidel referenced, next month, we will be welcoming Dr. Rosick from UCF, who has joined us before and is an excellent speaker on suicidality in first responders. Next month is an entire month dedicated to suicide prevention. So make note, look at what you're interested in, and this will be posted to, our Facebook page, as well as other social media platforms. So we hope that you'll join us on some of the discussions of suicide. We know that during the Surfside tragedy, Palm Beach was facing tragedy of their own in losing members to cancer, and also a member who died by suicide in the firehouse. So we're really trying to make a difference with our families, with the youth, with our kids, our first responder kids. We'll talk about that, and first responders in general. So with that, the recording's still going. So if anybody has questions that they're willing to ask on the recording, we'll go ahead and start with those. And if not, we'll go ahead and stop the recording, and we can have that confidential peer support talk amongst ourselves. That is part of the reason why we started this platform, to really create a network of peer support where we can speak put my senior teeth in here.
In secret.
Oh yeah, got a birthday coming up and it's showing. Yes, and where we don't have to run the risk of being judged or being identified by our departments as well. So, so I'll open the floor in the chat, or taking yourself off mute. You don't even have to identify yourself if you have any questions for Dr. Beidel.
Hey, I do.
Hi.
Hey, how are you?
Well, how are you?
Great. So the 3-week program that you were speaking of for Surfside, would that be just because of everyone from different areas via Zoom?
Right now, we're willing to do it in person with everybody wearing masks. But if people want to do it by Zoom, we can work that out as well. We've done a lot of our programs last year over Zoom, and we know that it works it's as effective. The only thing we lose is we can't do the virtual reality over Zoom. But you know what? The program works just as well. The virtual reality is really nice. I think it adds a dimension, but the program is still effective. So, but like I said, we will be setting those up if people want to participate. We do have, I said the funding is there. I know not everyone can get away for 3 weeks because of childcare responsibilities or everything else, but we do have funding for people to stay at the Homewood Suites. We keep that there. You can go home on weekends and we keep your room. And we also have funding if people need help with transportation.
Great. Thank you so much.
Mm-hmm.
I have a question actually, real fast. You have that single session line. What if I'm a family member who's concerned about my first responder? Am I able to call that single session line and maybe have that conversation to come up with a game plan for my loved one? Or is it more beneficial to get that first responder to call?
It would be more beneficial for the first responder to call because, as we know, it's often hard to get other people to do things. But you just gave me a good idea that we might, because why not, right? So, but why not? I mean, maybe as a family member, you're having a lot of stress yourself or don't really know how to deal with it. And so maybe that line might be good for you to talk about the stress that you're having and what you could do to help yourself, feel less stress and then help your first responder as well. So I'll talk to the clinicians about that and we can see, because we really do want to use it. We really do think, again, that it's effective for lots of people, particularly in this time of COVID when not everybody can commit to going to therapy because of, everything else that's going on.
Absolutely. We do have some people in the chat that are interested in that 3-week program.
Okay.
What's the best way to get a hold of someone to discuss that?
The best way to do that is to call Monica at our clinic. I can put the number here. Her name is Monica. She is our clinical care coordinator, and the number is 407-823-3910.
Thanks so much. 407-823-3910. Monica has been amazing. Used her a lot during the time of Surfside in connecting a lot of our first responders there. For those of you that don't know me, I'm a firefighter paramedic with Miami-Dade Fire Rescue, so the responding agency, and Monica was just phenomenal in getting our guys as quickly as humanly possible to connect with therapists. So thanks so much for that.
And we do have, the other thing is, we do have that list that Chief Bader and I put together on culturally competent therapists in different areas. So if someone is interested and, they're over in Tampa, for example, and they don't know if they really want or can do a 3-week program, they can call our office and I'll make sure Monica has that list and she can give you the names of some people who are either on Redline Rescue or should be on Redline Rescue, but maybe aren't on there yet, but who have taken the clinician course and are doing treatments that we know have some effectiveness. They may not all be doing our treatment, but we've vetted them and know that they do treatments that have some evidence behind them. You all deserve the very best treatments. You shouldn't be getting like weird things. Okay. So we want to make sure that we refer you all to someone that we wouldn't be embarrassed that we sent you to. So.
Thanks so much, Dr. B. Any other questions that we can ask? We are recording, so I will say that.
I have a question.
Hi, Sam.
Dr. Beidel, my name is Michael. Yeah, I had a question regarding sleep. As a retired first responder, I could tell you that sleep is one of the things that I've prioritized now, didn't necessarily prioritize before.
Right.
I've heard about some of the things that you discussed, different parts of the brain, processing of memories and all that stuff. So you discussed a lot of things not to do. Mm-hmm. But what can you do, especially if you're someone who's working shift work?
Thank you. Shift work makes it difficult, but some of the things that you can do are, first of all, keep your room temperature between about 68 and 72 degrees. A lot of us keep our room too hot, and that makes us wake up. So get the temperature down in your room to between 68 and 72 degrees. The other thing to do is don't stop your exercise at least 3 hours before you go to sleep. Okay, that's the other thing, because exercise just kind of gets you excited. Put those devices away. The other thing you can do is to do a relaxing activity before you go to sleep. So whether that's listening to some classical music or whether that's doing a little bit of yoga and stretching, maybe reading like a real book as opposed to an e-book. Those are things that can be helpful. The other thing that can be really helpful is not to lay in bed and try and make yourself go to sleep. If you get into bed and in about 20 minutes, if you haven't fallen asleep, get out of bed, okay? Because we don't want bed to become associated with bad things. Bed should be, we say, for sleeping or for sexual activity. But otherwise, get yourself out of bed and go read a book in a different room until you're feeling sleepy again, and then go back to your bed and go to sleep. So those are the things that you can do that will help you. And oh, another one that's really good. As much as you can on shift work, on the other days, go to bed and get up at the same time. Believe it or not, you can't really catch up on sleep. We all think we can, but our body says we can't. So do that, even on weekends.
Great. Thank you very much.
Sure.
I have a question.
Mhm.
First of all, thank you so much for the information. Obviously, it's an honor to have the level of expertise that Michelle and the collaborative has brought to the table in situations like this. We had a great attendance here, obviously tonight, so it's great that this information is getting out there, and we are going to be sharing this again, which is great, so others can benefit from it. You mentioned something earlier. I just retired, but I still remember moments where mental wellness in our department was handled incorrectly. I have moments when it was handled correctly. One of the charts you showed was an understanding that sometimes clinical intervention is fired off too soon. And I personally believe that we are in a culture where early doesn't work. There are a lot of walls that are up. We built perfect castles around our minds and our hearts in these situations and scenarios. And if a responder is asked to contribute or to intervene or to engage on what they just experienced, and please feel free and feel comfortable to open up and tell us what areas this touched your mind, your soul, your spirit. Sometimes that's too soon. And I like I said, I have some specific examples of that. How do you determine where or when it's appropriate to start that discussion? And obviously, take for instance the model CISM, where they come right in and we started debriefing and diffusing a scenario where we look at this right off the bat. I just think that at what point do you think the best time to intervene would be? I have another question, but that's my first one.
So I think the first part of that is a couple of weeks later, sort of generally is a good time. Now, one of the things that you can do, there's different types of these diffusing and debriefing models. And one of the things that seems to be problematic is actually forcing people to talk. And that was the mistake that was made very early on. There was actually a study done after 9/11 with firefighters and police. And firefighters were told they could go to debriefings, and police were forced into debriefings. The police a year later had higher rates of PTSD. And it was really related to the fact that they were forced to go in and to talk about things when they didn't want to talk about them. One of the things that we tried to make very clear down at Surfside was that we were there to do what's called psychological first aid. Psychological first aid is going up to people, making sure they had the support that they needed, the physical support. So, I'd go to the food tent and go, hey, you guys don't have any cookies. Let me go get you some cookies, right? Do you have enough stuff to drink? And then you just say, how are things going, right? And you let the conversation go from there. So the idea of psychological first aid is you let people talk, but you don't force them to talk. And you don't say, if they say, man, that was really a bad day. I found something I didn't want to see. You don't say, well, tell me about that in detail. You say, oh, really? And you just let the conversation go. You let people tell you what they want to tell you, and you don't force them. And that is much more effective than going in there, locking everybody in the room, which was done early, telling people they couldn't leave, and then making everybody talk about things several different times. So hopefully most of us have gotten away from that and doing something in a different a different length. But what we found after Pulse too was that a lot of people didn't really understand what was the normal reaction. So, and I found this, I was the chief psychologist when the Amish girls were killed in that schoolhouse in Nickel Mines. So this was in the Amish community where, you know, things like this just didn't happen. And what we found is that people didn't know what reactions were normal or typical after this kind of trauma. So they were very, very worried that they had developed a psychosis or something, when in reality, we're saying, no, it just happened. You should feel that way. You should be thinking about it a lot. It should be hard to eat. So part of what you can do early on is just talk to people about what typical responses are, and then just let people ask questions or listen as they want to tell you what happened.
Thank you. That was
Sure.
excellent.
I heard you mention during your talk that UCF is offered only to in-state first responders in Florida. Is that correct?
Well, the money that the Florida legislature gave me is for first responders who live within the state of Florida because it's state money. However, we have very generous donors who have given me a different pot of money that I can use for people who are out of state. So we can offer treatment to people who are out of state also at no cost. I just have to make sure when we do the billing that we're billing the right pot of money. But we do have very generous donors. Again, going back to Pulse, one of our donors called me the day after and said, I'm sending you a check for $20,000. Use it to treat people who need help after Pulse. So that's the kind of people who believe in us, and we're very thankful for that. So.
Amazing, amazing. And we know that we had urban search and rescue teams from all over the country that came down here. So that's why I really wanted to ask that question.
And you know, we're hoping to be able to help with the urban search and rescue teams who were down there as this goes forward, because we know what happened. We were there, and our commitment is we're going to be there whether we refer them to someone closer to where they live or whether we tell them to come down and see us. So
awesome. Thanks so much for that information. Any other questions before I stop the recording? And then go for it, Sammy.
Okay, this might be better directed to Chris, but I'm certainly Chris Bader, Chief Bader. I don't see Jeff Orange on, and I'm curious about just from a 30,000-foot view, perhaps anybody weighing in on this that's been involved in these bigger incidents. You know, your 9/11s, your Surfside collapse, your Pulse nightclub shooting, your Vegas shooting. When it gets down to the individual interaction or treatment from the clinician to the responder, I'm not sure if I can formulate this question correctly. How do you find it different when you have this tragedy versus a single tragedy where maybe you've had 3 or 4 pediatrics burn up in a structure fire and that crew is there. That crew is there's an impact there. You see a difference in the larger incident response, not logistically, but to the responder itself, that type of treatment. Are they very similar in treatments, the smaller scale incidents versus something large like this? I don't know if that makes sense.
Yeah, and I don't know if that was directed to me, Sam, but we treat everyone's trauma individually. So I think, you know, when you have these much larger events, there's more public attention on it. People really focus on it for a while, and then unfortunately, the next thing happens, and sometimes people feel that, you know, no one's really thinking about them anymore. But the traumatic event can be, you know, one individual within the scope of a large event who may have the most horrific experience, or who may have the saddest experience. I'm thinking about the people who found the daughter of the city of Miami firefighter. So it wasn't even so much that people were finding people down there, but that particular group found someone they knew or found someone of someone they knew. And that's going to have a different effect than if it was someone that you didn't know, right? Because there's a different kind of connection there. And that can happen in any kind of event. So, we know people who have unfortunately gone to accidents and found neighbors or friends who were one of the victims of the accidents. But everybody's trauma is individual, and we do what we need to do for every person, whether it was a large event or, like you said, a singular event.
Okay. I know that Chris has been involved in a number of those types of incidents. That's why I kind of mentioned him, but thank you so much for your answer.
Sam, that's where I met Chris at Parkland. So,
yeah, I would say that each one of these incidences are independently different, whether they're large scale, like Surfside, from the perspective of the Parkland thing, very, very different type of incident completely. And I'm just looking back, and I know a lot of people don't know how the whole deployment really played out, especially from the state perspective. This was 2 years worth of work back in 2018 when the state, multiple people that are actually on this call here tonight that worked to try to develop a plan and really learn from lessons learned from Hurricane Michael and the Panhandle of the lack of resources, of mental health resources that were provided to a specific region. And 2 years worth of work down the road, the actual model that was deployed was actually approved in December of 2020 by the Joint Council as a deployable model. So this was actually the first time it was deployed. There's certainly some lessons learned here too. But to answer your question, each one of these things are completely independently different. I've certainly learned so much from what happened at Miami-Dade and the people at Miami-Dade Fire Rescue as well as all the different agencies that responded to that. And, we're working with the state to kind of develop our after actions review to kind of share exactly those experiences so that the next time this happens, we're better prepared for it. And, I think from the Parkland perspective, I learned so much from what happened in Orlando. And I think that's the only thing we could do as we move forward, whether this is another Surfside incident happens or any other incident. We have to take the lessons learned from each one of them independently and then share them so that we're more prepared the next time this happens.
Chris, one question on your response down there in Surfside and probably what happened after Parkland and Pulse. Are you who maintains the list of and maybe the disposition of the responders that you need to get back to? The doctor talked about 2 to 3 weeks, maybe, checking back in with them. How does that look logistically? Just quickly, how does that look? Is there a list? Is there a database?
So primarily, obviously, it's going to be the affected agencies that were actually responded. But what we did through that response is, our specific mission from the state was to work with each. It was focused on this task alone. It was to support USAR teams that were being deployed, state assets, and to help support anything Miami-Dade Fire Rescue needed. So our goal was really never to come into Dade County and take over or do any other type of thing like that. It was really to help support what they were already working. They already had many resources in play, and really what we were there to assist in any of those type of operations. And specifically, there were 3 operations related to mental wellness that were ongoing. One was the actual the incident, the site incident. The actual stations were also visited, and then the family support component, which Michelle was at as well as our chaplain. So there was 3 operations that were constantly going 24/7 for a period of time. Slowly, as those USAR teams started kind of moving out, some of those resources were also moved out. So it's quite a big operation, and as Deborah mentioned earlier, one that lasted well over a month. So a lot of people did a lot of hard work over that period of time. And even after each USAR team deployed or actually was demobilized, our team met with each one of them to kind of go over the resource that we're talking about now. And then Dr. Beidel and others worked with the regional components. So as they went home, there were already resources and contacts waiting for them to receive them. to make sure that they actually had what they needed when they got home. So those contacts were made with every USAR team leader. The state was also sending messaging on that. And then we also deployed a actual follow-up plan that was sent out to every USAR team that, again, many of this, the people that are on this call worked to develop. Dr. Kelly O'Dare, as well, also Dr. Beidel, Jeff, certainly, and create basically a guideline for agencies to work off of. And it didn't really mandate that they had to use it, but it certainly gave them a template to work off of. So how do you approach that? For example, waiting a period, a couple of weeks before you actually try to, have or have some sort of meeting to kind of let people to digest exactly what they saw. And what we find is every time people are really working an incident, they only focus in on the area that they're at and don't necessarily know the whole picture, and they fill the void with images on TV or things like that. So this was really a good perspective for a lot of people to kind of get back. And those USAR teams have already some of them already have had that meeting, that follow-up meeting. I know that some are still currently working on through that based on the timelines that they actually left. So that's kind of and now we're going to be waiting for an approval from the state for a follow-up survey that Dr. Beidel and team put out to help even follow up with some additional research and assistance.
Thank you, Chief.
Yeah. And we're hoping to make some of these lists and stuff, Sammy, available on our collaborative website in the coming weeks as we get a chance to regroup and get together and, get the finer details put out so that other departments, when they're experiencing larger incidents, can just head to our website like so many other things and get these free resources downloaded to help guide them in the future. So great question. All right, with that, I am going to stop the recording, but first,
Wait.
Yep, go.
Wait.
Who invited Sammy? No, I'm only kidding. We love Sam.
One last thing. This is not a question. I think about what's happening here, and I know, I feel like this mental wellness, huge collaborative effort that has started back in 2017, 16. I don't know when we started, but we have a portion of that, but there's a huge statewide response. And now UCF Restores being involved. And I think about what the Lord, in my opinion, has laid in front of us. And I look at this, I can't even conceptualize what Stoneman Douglas would have looked like without the preparation, what the Surfside thing would have looked like without the preparation. There's been a lot of work that's been done, and Dr. Beidel, think about this. You literally locked arms with us, and then all of a sudden we've got this huge need. Again, it happens. It's not like we knew it could, but look at the incidents that we've been involved in, and we've been able to collaboratively with many organizations and agencies and a lot of great souls involved in this, mount a formidable response to it. And I'm just very grateful to being part of this team, but also part of the larger movement, if you will. So that's just something to think about. I think it's amazing.
Thanks, Sammy, for those kind words. And I kind of dropped in the chat also that Second Alarm project that has been along with us for the ride now and is our partners in crime up in the Panhandle. I can't say enough about Kelly O'Dare and the work that she's doing up there, not just up there by herself, with her group and in conjunction with our group. And as a team, us, Second Alarm, UCF, like ANOVA, all these places that just want to come together for the betterment from their heart. Dr. Beidel, for those of you who don't know her, is a force to be reckoned with. She is. But the thing with her is that the passion that she says she has for first responders is second to none. And it is the most genuine passion of anyone I've ever met. So when you say something, she says, oh, that gives me an idea, because she doesn't want to put no in the vocabulary to helping first responders. And when I asked her, hey, can you come on? It's past your bedtime, Dr. B, we know this. can you come on and have a conversation? She was like, yeah, of course, tell me what's going on. In fact, she was the one who was on top of me with all of the details. So Dr. B, thanks so much for your time and attention tonight. We can't thank you enough for everything that you do for our communities, for our family members, and we look forward to the growth of that relationship. Thank you everyone who's joined us. We are going to stop the recording now and continue the discussion. I know Dustin wants to give a few closing comments. So once again, Dr. B, we'll see you everybody. Hopefully we'll see you next month for our Suicide Prevention Month. Thanks again.